This fits with my practice very well. As a tertiary, even quaternary referral specialist in the Philadelphia area, we're sent patients that need help, and that means we have to do the right diagnostics and make the right diagnosis. We've got multiple offices all over the Philadelphia and South Jersey area, so being able to use a device that helps us with osmolarity testing, the portability of the device, and the ability of it to let us make an accurate diagnosis is critical in us being successful for patient care and helping manage patient expectations. So patient expectations and lab testing are a big part of the pre-cataract workup. I can't tell you how many patients come into our office expecting to be scheduled for cataract surgery, and we have to delay that surgery because they have concomitant dry eye. We make that diagnosis based on topography and lab findings such as osmolarity. And having that accurate diagnosis, rapid diagnosis, helps us pre-treat those patients so when it does come down to their surgery, we have a better outcome. So when you look at the algorithm set out by the ASCRS for pre-surgical management of ocular surface disease, physical exam is critical, but so is diagnostic testing. Having these different touch points with the patients and different diagnostics allows you to properly diagnose and treat the ocular surface prior to cataract surgery. And at this point, I think it's well known that proper management of the ocular surface leads to more happy patients. The ASCRS Essential Guidelines looks real simple. Now that it's printed, all you see is this algorithm looking at the pre-surgical patient and arrows pointing as to how to manage that patient and manage the ocular surface prior to surgery. What it doesn't represent is the days, months, weeks, and even years that it took to come up with that guideline. I'm pretty spoiled. I got to be an author on that paper coming in very late in the committee, but they spent countless hours diagramming, looking, trying to make things make sense. And a critical part of that algorithm is point-of-care diagnostic testing, whether you're looking at MMP9 or specifically looking at osmolarity, and helping surgeons make the right decisions and treat the right patients prior to their cataract surgery to help improve incomes and improve patient satisfaction. In our office, we've used osmolarity for years in helping us diagnose and treat patients with ocular surface disease. And I can't wait to start using the new ScoutPro as it's so much more portable, it's precise, and it's going to allow us to have patients from all different offices to help make the right diagnosis and improve treatment. I think another advantage of such a small device is that this is simple. It's going to fit in our technicians' pockets, and they can just simply walk around with this in their pocket as they're treating and working up patients, as opposed to going back to the instrument every single time. Anything that saves a second of time in the office is going to be much more acceptable and help us with patient throughput. So if I was to recommend something, or when I'm talking to my friends about point-of-care diagnostics, I've got to recommend the ScoutPro. I mean, being so small, the precision and the importance of osmolarity, this has got to be top line when you're diagnosing and managing ocular surface disease.